Thank you, Dr. Al-Sawaidi and Dr. Badr. Good morning. It's a great pleasure for me to be back in Doha and to see the progress that has been made in the city as well as at Sidra and also at QCRC, and to again be part of the vision of Sir Magdi and the leadership here at the Heart Hospital. It's also great to see Bill McKenna in his new role. We do go back quite a ways, Bill, and it's good to see you here and wish you the best in your new responsibilities. And I'm looking forward to the next 2 days. This will be, I think, a very interesting series of discussions about where heart failure is going. I apologize for the error there. It says global burden of heart failure, not global. Okay, what are the global trends in heart failure? What I'll try to cover in the next 20 minutes or so is dealing with the growing burden of cardiovascular disease globally, the improvements we're seeing in some but not all risk factors, but then the geographic variability in the etiology and the cost and the impact of cardiovascular disease and heart failure, and how quality improvement programs, which can be implemented anywhere in the world, can lead to a reduction in both inpatient and outpatient mortality. We certainly know that the global burden of cardiovascular disease is upon us, that the leading cause of death worldwide is cardiovascular. About 30% of all deaths each year are cardiovascular in origin, and 80% of those occur in low and middle income countries. It's not the high-income countries where we see the biggest burden. As we're seeing declines in cardiovascular disease mortality in some countries, in many other countries they continue to increase at alarming rates. And clearly there's a geographic variability. These data come from Greg Roth and Mark Huffman. Dr. Huffman's a colleague of mine at Northwestern. Just looking at the death rates per 100,000 in various regions of the world. And certainly in this region, one sees great variability from some countries that have very high mortality rates, Yemen, Egypt, Iraq, Syria, versus your country here, which is actually quite much lower. Still high, but lower than other regions in the world, and also within this region in particular. Here's a blow-up of the Persian Gulf down here. And so clearly there's wide variability in the risk. What we see as outlined by Roth and Huffman is that the age-adjusted mortality rate is declining globally, as it is in my country, in the United States. But this is the age-adjusted death rate. We have an aging population and a larger number of people, and so if we actually look at the number of deaths, not the death rate, but the number of deaths, that's continuing to increase. And what are the causes of cardiovascular death? Well, this is where heart failure becomes problematic, because if we go to the global burden of disease data published in the Lancet and otherwise, this is how cardiovascular disease is defined. We're looking at various issues of morbidity, mortality. And so we have ischemic heart disease, a leading cause, cerebrovascular disease, a leading cause, less important other issues. But where's heart failure here? We know that heart failure is the biggest driver of hospitalization for older people, certainly in my country and in the Western countries. But where's heart failure? Well, it's because heart failure overlaps many of these areas. So heart failure data are very difficult to come by. And I'll show you where we have some holes and gaps in our data, much of which are gaps here in the Middle East and in the Gulf. It's estimated that the prevalence has increased, perhaps doubled from 1990 to 2013. The actual number is debatable. I've heard usually the number of 26 million people worldwide. But Roth and Huffman, who argue again that it's the coronary disease and it's the hypertension that leads to heart failure, that perhaps it's even higher, perhaps as high as 86 million people. So somewhere between 25 million and 86 million people. It's a huge burden. And we're going to see continuing issues here. Now, we've had some improvement in some global trends and risk factors. Moving on to the next aspect of the presentation. Tobacco use from 1980 to 2012 is declining in global terms, but not everywhere in the world, for both men and women. Blood pressure, 1980 versus 2012, blood pressure is under somewhat better control. That's good news. But bad news is that physical inactivity remains a problem. Obesity is increasing alarmingly globally, not only in developed countries, but also in the developing countries. Diabetes, therefore, is increasing as a function of the physical inactivity, metabolic syndrome, obesity issues. And then cholesterol at least needs to be observed to see whether we're getting good enough data and control of hypercholesterolemia. And so we still have burgeoning risk factors that lead to more coronary disease, which leads to more heart failure. And so if we go back to the global burden of cardiovascular disease, where do we begin to see the regional variability in heart failure? Again, data are difficult to find, but one can find papers. Here's a look at worldwide risk factors for heart failure by Katzabab and co-workers, and I apologize for the pronunciation. Dividing the world, as we often do, into various regions, the Western high-income countries, the Asian Pacific countries, Latin America, and so forth. But look here. They've divided the world the way you do in Harvard, and there's no data in this paper from your region. And yet we're going to see very important data emanating at this meeting from investigators here in the Gulf who actually have very good data regarding the epidemiology. India is also not representative, and India has a huge issue regarding heart failure. Well, what this paper did was to break down these various regions of the world here into various etiologies, just to expand the top panel here. It seems that ischemic heart disease and hypertension are the leading causes of heart failure. That's to be anticipated. In the United States, it's estimated that 60% of heart failure is related to coronary disease. In India, I was at a meeting 2 weeks ago in India on heart failure. 70% of the heart failure in India is from coronary artery disease. And with coronary disease being such a huge contributor to morbidity and mortality in this region, undoubtedly ischemic heart disease will be an important contributor. So I look forward to seeing the data as we discuss it later this morning regarding the data from the Gulf Registry and from here in Doha as to the etiologies. But ischemic heart disease and hypertension are the leading causes, less so, but still important, valvular heart disease, less so cardiopulmonary disease. Cardiomyopathies are important, clearly genetically driven in many cases, and in some regions of the world actually pop up as being very important. Latin America, Chagas disease, Sub-Saharan Africa, also a very important area for cardiomyopathies as well. Okay, well, so in the U.S., we see that the data as we estimate it from the American Heart Association is roughly 5.8 million people, $31 billion in healthcare expenses. That's total direct and indirect. 1 million hospitalizations per year. Here are the annual cases and deaths. But this is increasing in the United States. And it's estimated by Heidenreich and co-workers from 2012 to 2013 with aging of the population and the fact that we treat patients with heart attacks and keep them alive, but now they're alive with weakened hearts. We're going to be having an increasing burden of heart failure. So the number of patients with heart failure is likely to increase. The costs of heart failure are going to double and maybe triple over the course of time. So now the economics of heart failure become important also, and we actually have some estimates of the global costs of heart failure in this paper by Cook and co-workers, currently online at the International Journal of Cardiology. It's not out in print yet, but the electronic version is available to you. They're estimating the overall cost of heart failure worldwide is $108 billion. So the high-income countries are here, United States contributing those numbers we saw earlier, but the total is about $108 billion. They then drill down to each region of the world and each country in the world. So now we actually can begin to look at least the estimated cost of heart failure care and impact on the economies, not only in the Western countries, but also in several countries in the Middle East. This is interesting. So here's Qatar, $151 million annually. Here's the United States, $30 billion annually. Well, we also have a larger population. We have 318 million people compared to your 2.6 million people. So we can estimate what the cost is per person, not only from the United States and the Gulf region, but also these other countries here. And if you go to the paper, every country in the world. And this is the cost per person for treating heart failure. USA, Japan. So the Western countries are pretty uniform. UK is a little bit lower. Canada is actually higher than the US when we talk about this on a population basis. But Qatar actually is very similar to what we see in the Western countries. Less so Saudi Arabia, Emirates, and Kuwait. But Qatar is economically impacted by heart failure per person, just the same as we see in the Western world as well. And so if you look at this map now from the same paper, looking at the overall cost per capita, which is what we saw in the last graph, the color code is here, and if we could actually blow up Qatar, you'd see it's as green as the United States. But it's in the developing countries where we have this impact globally of increasing cardiovascular disease burden, and there's much less attention paid and much less economic support for health care. So this is the global population in high-income countries versus the middle and low-income countries. And what one finds is that the per capita global spending is $70 per person in the high-income countries and $3 per capita for heart failure in the low-income countries. And then finally, there's good data that as we move into the exciting new areas we're going to be talking about today with tissue engineering, gene therapy, device therapy as well, which are very, very exciting, and the future for heart failure. This all has to be built on a foundation of very good medical therapy. So the quality improvement programs have shown us that if we adhere to the recommended medical therapies of ACE inhibitors, beta blockers, one can find that the outcome of our patients is significantly improved. So this is the look at a registry in the United States of whether patients have an assessment of left ventricular function, and if they have impaired left ventricular function, are they treated with ACE inhibitors and beta blockers. And this is the odds ratio for mortality. And so just adhering to recommended guidelines-driven medical therapies leads to a significant reduction in the odds ratio for mortality. Dr. Georgiades and I had a chance to write the editorial about this, emphasizing that as we move the field forward into these exciting new advances in heart failure that we'll be talking about today, it's got to be based on the foundation of a quality program that provides excellent medical therapies as the underlying basis for that. We see it also in outpatient practices as well from these data from Greg Fonerow, 167 outpatient practices in a registry of heart failure outpatients, 15,000 patients. We look at these various quality indicators. Are patients receiving ACE inhibitors and angiotensin receptor blockers, beta blockers, anticoagulation for atrial fibrillation, ICD therapy, biventricular pacing, and just giving heart failure education, each of these. Patient centers and outpatient practices who have patients in which we conform to these accepted metrics of quality compared to those patients in whom one does not conform have a 24-month mortality which is significantly lower in the red bars compared to the non-conforming centers in the blue bars. So every 10% improvement in guideline adherence results in a 13% decrease in 24-month mortality. Now we see this not only in these registries in the United States, but also globally. This is a systematic review of heart failure quality improvement programs, not only in the United States, but internationally. And one finds in this paper very similar data that heart failure quality implementation results in halving of the in-hospital mortality compared to standard of care. And so clearly there's an opportunity for us everywhere, including here in Doha, to begin to look at how our clinical research leads to implementation of guidelines, quality indicators, performance measures that we can begin to define and measure how well we are performing. That leads to better outcomes. And that can also feed back into more research to make the system work even more efficiently. And then finally, there's a very good review of the global heart failure epidemic in this publication from the World Heart Failure Alliance. Just to show you a few pieces of information that I gleaned from this particular publication related from the European Society of Cardiology and the European Heart Failure Association. Here are some data looking at heart failure mortality in Africa, Middle East, North America. Here is Qatar. And one sees that the in-hospital mortality for heart failure admissions is very similar in Qatar compared to other countries in the world. If one looks at other data in this paper regarding the prevalence and the number of hospitalizations and so forth, Qatar fits very much into what we see in countries that are performing quite well. But what's lacking is this issue, which is looking at the places where we have guidelines. We have guidelines from North America, we have guidelines from South America, guidelines from Europe, even in South Africa. But we need to develop guidelines for care of your patients as well. So that's one thing which seems to be lacking at the present time. Now maybe I could be missing, and perhaps you've got those guidelines, or maybe you've just adopted the guidelines that are already implemented in Europe and the United States, and perhaps that's driving the quality we see in your patients as well. And so what these authors point out is that as the progression of heart failure moves from those at risk of heart failure to those with worsening heart failure, at risk of dying from heart failure, where these new therapies that we're talking about become very important, there are steps along the way to block this progression, including healthy lifestyle, eliminating infections in those parts of the world where there may be infectious etiologies, identifying and treating patients at risk, greater public awareness as well as physician awareness, and then applying the best practices in those who have heart failure to, as much as possible, prevent the inexorable progression of heart failure to the point where we need more advanced therapies. And then underpinning all of this is the research to address the urgent unmet needs at each step of the way. And today we're going to be discussing a lot of the exciting areas in these unmet needs. So just to conclude, I hope to cover these four particular areas where we have some data, inadequate data in some places, the need to develop more data, but clearly cardiovascular disease is a growing burden globally. Heart failure is driving much of that, and the advances we'll be talking about today and the future of heart failure treatment, I think, is going to open up new avenues for opportunities for our patients to have better outcomes. Thank you very much for your attention.